Hi, this is Nicole Mercado, and today I'll be discussing epiglottitis and giving a brief overview of the topic. So we'll start with the definition. What is epiglottitis? It is the acute inflammation of the epiglottis, supraglottic region, or other nearby structures. It's most commonly caused by Haemophilus influenza type B, and since the development of the Hib vaccine, there's actually been a 99% decrease in the number of invasive Hib cases in the United States. But that statistic applies to not only epiglottitis, but also meningitis and pneumonia that are caused by Hib. Currently, the Hib vaccine is recommended for children under 5 years old in the United States, and the first dose is given at 2 months old, second dose at 4 months, third dose at 6 months, and the final booster dose is given between 12 and 15 months old. So despite the use of the vaccine, there is still a persistence of epiglottitis, and a few reasons have been suggested for why that is. The first is failure to receive the proper immunization, which occurs in the patients who just refuse to get vaccinated. Failure of the Hib vaccine itself, and a UK study actually concluded that the vaccine is 98% effective. Finally, there are alternative causative organisms that have been identified causing epiglottitis, including group A beta hemolytic strep, Staphylococcus pneumococcus, Klebsiella, Pseudomonas, Candida, and viruses. So moving on to the clinical assessment, the picture shown on the slide shows the classic presentation of epiglottitis, which is an acute onset of stridor and drooling in an irritable child who is sitting in the tripod position. So you can see in the picture the tripod position consists of sitting stiffly, holding oneself upright using both arms, and simultaneously holding one's mouth open with the neck outstretched. But since the development of the vaccine and as time has gone on, it's actually evolved from the classic presentation and occurs more often in adults now than it does in children. So some more common symptoms for us to look for in the clinic and the hospital would be severe odynophagia, drooling due to inability to swallow one's own saliva, sore throat, dyspnea, tachycardia, fever, hoarse or muffled voice, and stridor. And again, those are the more common symptoms that we would look for in real life as opposed to the classic presentation seen in the image. So, on to diagnosis of epiglottitis. To diagnose it, soft tissue radiography is usually done to screen the stable patients and determine if laryngoscopy is necessary. And we know from lectures and exams that the pathognomonic sign for epiglottitis is the thumbprint sign, and that's seen there in the top right corner in red. So the thumb sign is a round shadow protruding from the epiglottis on lateral neck radiography, signifying thickened and edematous tissue. Another radiographic finding is the vallecula sign, which is seen in orange above the thumbprint sign. And that is when the vallecula is no longer well defined on radiography due to obliteration from epiglottic swelling. One study found the thumb sign was only seen in 77% of cases, and the vallecula sign in another study was found to be 98.2% sensitive and 99.5% specific. So those are the only two studies that have really been performed, and the accuracy of using the signs for screening is still uncertain. And that brings us to our gold standard of diagnosis, which is nasopharyngeal laryngoscopy or indirect laryngoscopy. And you can see in that bottom right corner on the right-hand side that you can directly visualize the epiglottic edema, and sometimes you might see swollen arytenoids, a narrowed airway, an epiglottic abscess, and swollen vocal cords. And that brings us to treatment. So a really common test question in patients that you suspect epiglottitis in, what is your first step? And that is emergent airway management and observation. That's the most important part of treatment. Along with that, you can empirically treat with IV antibiotics, and you can use amoxicillin clavulanic acid or a third-generation cephalosporin by itself, but oftentimes metronidazole or clindamycin are added. Some complications of epiglottitis, if unrecognized for a long period of time or left untreated, include upper airway obstruction, which is why the immediate airway management is necessary. And some other complications may be abscess, and it could also lead to death. So for prevention, like I mentioned before, Hib is the major causative pathogen of epiglottitis. So vaccination, receiving the Hib vaccine, is the most effective method for epiglottitis prevention. Finally, in cases of actual diagnosed epiglottitis, you can give rifampicin chemoprophylaxis to prevent secondary transmission to their close contacts. but that's not typically recommended unless it's caused by Hib. So all the other causative organisms that we listed on the first slide, that wouldn't apply to. And that concludes my presentation. Here is a list of the references, and I hope you all enjoyed my presentation. Good luck on the quiz.